So we're waiting for Wayne, hey?
Yes, we are.
Victoria, you are going to start the recorded versions.
Yeah, so we'll start recording once we broadcast, and I'll probably broadcast in about a couple minutes.
No, I mean I sent you the sound overlay version. So
Oh yeah. So do you?
start that.
I asked everybody else, except I didn't get Lucia's answer. Do you guys? So Awolabi and Jorge want to do? They want to try live first, and then if it goes wrong, then I'll pull up something.
I prefer the recorded version for the positive time.
Okay, then we'll just leave it that way, and we're ready for question and answers. Is that okay? Okay.
Okay, wait. Sorry. Rewind.
So Volker, I'm going to make some introductory comments and then turn it over to you and Wayne. And each of you have a few comments.
Mhm.
I think Professor Braga's got the next lecture, so I'll introduce everybody briefly before
So
their
what's the sequence? We have Lucia first,
Yes.
Wayne and me first, and then Lucia,
Yeah, Jorge,
Jorge.
yeah.
Okay, wait. So Boker, you want me to use the recorded version of your talk?
Yeah.
Dr. Fang, I don't know, but I assume he's going to want to go live. Dr. Braga, do you want to go live or do you want to do recording?
Got her
She's muted.
at the microphone. You should.
I think live is okay.
Okay. Then Jorge, you had said you wanted to do live first, yes?
Right.
But-
Okay.
Jorge is always
Okay.
best.
Okay.
What does okay mean? Does that mean recording or does that mean live?
Live, but Volker just said that he suggests recorded, so it's okay
No.
with me live. Live is okay.
So for the short introduction, I think it's better if it recorded because it's just more compressed.
Okay, then we'll go with the recorded way. Okay.
You
Okay.
can do it live. So make
It's
it
6 o'clock in the morning for me,
live.
Volker. Don't demand so much from me.
Okay.
Okay, so well, I'm going to go record it or not, Volker. So, what do you suggest? We go record it?
Your choice. Like, go for the recorded version.
Yeah. Okay. Then Victoria, go for the recorded version. Okay.
Okay. Dr. Owolabi, do you want to do recorded or live? I have to triple check.
Yeah, I am going to do live. We
Okay.
will use the recording as backup.
Okay. And
Otherwise, a
Dr.
live recording.
you.
So
Dr. Surya, live or recorded? You're muted, sir.
Victoria,
I
I
haven't
cannot
sent
start a
you
video.
my presentation, so it has to be live.
Okay, you're gonna do live. All right.
Victoria,
Mm-hmm.
I cannot start a video because the host is stopping it.
I know. I had to make everyone co-host. There you go.
we have
Go
the
ahead.
same problem, Wayne.
Mm-hmm.
Hey, good morning.
It's okay. I found a workaround to fix it.
Great. Morning.
Oh, there's Wayne.
There he is. Good morning, Wayne. Good
Good
morning.
morning.
Good morning, Wayne.
Hey,
Good morning,
Very
Dr. Fang.
professional. Yeah.
Yeah.
I don't have to ask this because I know, but just to make sure, Dr. Fang, do you want to do your presentation recorded or live?
Live.
All right. Pull up Dr. Boker's presentation then.
So Wayne, I'm going to introduce you first then when we get to the introductions, and then Volker can go right in. I'm going to introduce both of you at the same time.
okay.
You can start and then Volker can jump in when you're done.
Sure. I only have a few slides, just talk about several initiatives we have, just kind of introductions.
Right, exactly.
Okay, you guys ready to broadcast?
Right, so we're going to alternate between this and the next slide, Victoria, right? Yes, perfect.
All right.
Okay, we
It
have
should-
2 minutes,
Alternate back and
2
forth.
minutes to go.
Yep.
it
4
should-
minutes.
just triple check. Yeah, it's on a rotating.
So about 5 minutes, we'll start then.
Yes, and we should probably go live in about 1 minute.
Yeah.
We should mute our. You should mute until we speak, right? Yes.
Yeah, for the most part, if everyone could try to be muted whenever they're not talking, just remember to unmute yourself when you go to talk. If I see that you're trying to talk and nothing's coming out, I'll request for you to unmute yourself and you'll get that little pop-up. All right. We've got that shared and we're pretty much ready to go. So I'm going to go ahead and broadcast so that we can start letting people in.
Uh,
Do you have any objections?
no, Victoria, we still gonna have a poll in the middle, right?
Yes, so the poll, I included everything from last time, including that question about the whether they would be willing to pay for that virtual symposium that you guys are planning to do. Do you want to include that question or do you want me to delete it?
I'm sorry, the last question, I didn't hear that part.
The last question that was about whether they'd be willing to pay for the your annual conference, even though it's virtual.
Wait, it's David the call, David the vocals call. David,
Dr. Good, you're muted.
David, you muted.
I think we should delete it.
Okay.
Yeah, we'll go, Tracy. Tracy says delete it. That's
Okay.
fine.
So it's just what content are you tuning in from? What is your age group? What is your profession? Have you had experience taking care of COVID positive patients?
Yep.
All right. All right, broadcasting in 3, 2.
Ready to go.
Okay.
Welcome, everyone, to the third World Federation for Neurorehabilitation webinar related to the coronavirus pandemic. Our topic today is challenges, neurorehabilitation needs and strategies for COVID-19 in the developing countries. We've got an outstanding group of speakers today, and I think you're going to enjoy the webinar. We've asked each speaker to speak for 20 minutes, and then we'll follow this with 5 minutes of questions. If we have time at the end of the webinar, we'll also have a panel discussion with questions and answers. Now, when you submit your questions, please use the Q&A feature on your Zoom. We prefer you not use the chat feature. We have a very large audience and not all the questions can be answered. But when you submit your questions, if we can't address them verbally, then each speaker can try to adjust them with the Q&A feature, answering them back to you. Now, many of you are probably interested in continuing education credit. Information will be presented at the end of the webinar about how to request continuing education credit. The entire webinar will be available on the WFNR website probably in a week or sooner. 2 final items. I'd like to invite all of you to attend the 11th World Congress for Neurorehabilitation to be held the 7th through the 11th of October. You're seeing, there's a slide right there with the information. This was originally going to be a traditional in-person Congress, but it's been converted to a digital Congress because of the international pandemic. But there are still some outstanding plenary sessions, symposia, and workshops that I'm sure you would enjoy. Registration's available on the WFNR website. Now, finally, I would like to thank Duke University for their outstanding technical support. Thanks to Dr. Wayne Feng for his organizational leadership and Victoria Stabile for her help here during the session. She'll be also taking your questions and fielding them to the individual speakers. Now, I'd like to introduce two individuals who are going to give some introductory comments. The first is Wayne Feng. Wayne is a professor of the Department of Neurology at Duke University Medical Center. He's chief of the Vascular Neurology Division and medical director of the Duke Comprehensive Stroke Center. His areas of expertise include vascular neurology, biostatistics and epidemiology, neuroimaging and brain stimulation. He's a fellow of a number of professional societies. He's a member of the World Federation of Neurorehabilitation Presidium. He's also the vice chair of the Neural Repair and Neurorehabilitation section of the American Academy of Neurology. He's a member of the editorial board of several journals. He's author of multiple peer-reviewed publications, and he's well-funded. Following his presentation, we're going to go directly into another talk by Professor Volker Hamburg. He's the head of neurology and medical director of SRH, the Gesundheitszentrum Bad Wimpfen, Germany. Professor Hamburg has had a distinguished clinical and research career. He's been the president of the German Society for Neurological Rehabilitation, and he's been the Secretary General of the World Federation for Neurorehabilitation for 17 years. He previously was Secretary General of the European Federation for Neurorehabilitation, and he's currently Vice President of that organization. He also has many peer-reviewed publications, many research interests, and I would say he's been a major factor in organizing many international congresses, including the 11th World Congress that we just talked about. So I'm going to turn things over now to Professor Wayne Feng, and then we'll go immediately into Professor Hamburg's comments. Professor Feng?
Well, thanks to David. Can you guys hear me okay?
Yes. No.
Well, thanks to David's leadership and welcome to the World Federation Neurorehabilitation sponsor COVID-19 symposium. As we know, COVID is a devastating disease, and as right now, all the condition is really try to save all the lives. But now we know this disease can infiltrate the central nervous system and affect a variety of neurological disease, and now really create tremendous needs for neurorehabilitation. And so with this, the World Federation of Neurorehabilitation had several initiatives, and as I point out, and right now we have 26 million in cases, 860 of a case died from COVID-19, and this slides kind of show you, and then the COVID-19 can link with GBS, stroke, and other neurological disease. So, and the World Federation of Neurorehabilitation actually organized several symposiums. The first symposium really focused on the impact of COVID-19 on neurorehabilitation care and the research. Our second symposium really focused on the neurological sequelae and of COVID-19, really talk about cognitive impairment. And today we have a group of wonderful speakers talk about the challenges and barriers in the Americans, African and Asian country, how they're battling for the COVID-19 in terms of neurorehabilitations.
Apologize for interrupting, Dr. Feng. Your slides are not advancing. And I'm assuming in your 9 slides, you might want to us to be able to see a couple of them.
Oh, it's advancing on my end.
So we're on the slide in the view where you would be able to edit the slides, but not in the presentation slide.
How should I?
Do you have two screens?
I have one screen only. Oh, I have two screens. That's correct.
You might have shared the wrong screen. So you might need to just exit out of your screen share and then share the other one.
Okay. Victoria?
Yep.
Okay. I have.
No worries. Worst case scenario, you can pull it up the same way and we'll just have you click through your slides in the view where you would normally edit it, and that's fine.
Well, maybe. Hold on a second. So. You see now?
1 second, it's just loading. Okay, so now we're on that intro slide. So maybe just do it that way. Perfect. Keep going. Sorry to interrupt everybody.
Okay. All right. Well, so this symposium really focused on the challenges in Americans, African, Asians, and then the slides. If you miss the symposium, and then the webinar will be broadcasting on the website. So this is really the website. Go to World Federation Neurorehabilitation. You click the webinar. At the same time, and then the World Federation Neurorehabilitation also have a research and a topic with the frontier called COVID-19, the neurorehabilitation perspective, and you can submit it this and to the frontiers on any topic with the COVID-19 and the neurorehabilitation perspective. And as David just pointed out, and the Congress is going to go live and go digital in October next month. And then even during the Congress, we also have several topics in COVID-19 neurorehabilitation. So with this, I'll turn to Vocal and thanks for attending the symposiums.
Okay, hello everybody. I have a pre-recorded version. I just want to, as an introduction, give you some some aspects of our current state of affairs, what we know and do not know about COVID-19. Just a couple of minutes. Victoria, you can start this. Hello everybody, and welcome to the third webinar on COVID-19 related problems, this time with a major emphasis on the worldwide spread of the virus across many countries and various continents. Let me nevertheless, as an introduction, go over some important issues. There are certainly a lot of remaining animals, giving us the impression, following the old Greek philosopher Socrates, that we know that we do not nothing. There's a lot of problems about outlasting immunity after infection or not. Is there a way to to use herd immunity as a possible means of getting rid of the problem, how infections of children as lockdowns of schools and universities certainly affect the educational system dramatically. Are there genetic determinants of disease expression? There are very fit young people without having classical risk factors who may even die of this disease. Is there a minimum virus dose to become infected? And finally, will we have and when a sort of vaccination to solve the problem elementarily? Know that the clinical phenomenology is really widespread. It's not just a lung disease. It's affecting a lot of organ systems, including the heart, the kidney, and especially hemostasis. There is certainly coupling to ACE receptors in multiple organ systems affecting the brain, the lung, the kidney, and hemostasis. There's a broad spectrum of neurological pathology arising from this. That raises the question of general pathogenetic features. There's a recent paper looking at vascular occlusion in the microvasculature by neutrophil extracellular traps in COVID-19. If microvascular mechanisms play a major pathogenetic role, that may open an avenue for treatments by high-dose steroids or high-dose anticoagulants as heparin. Another major issue is the way of transmission of the disease. We know it's transmitted by droplets, possibly aerosols, and this paper looks into detail at the spreading by asymptomatic patients. And the majority of spread, the majority of outbreaks are due to clinically non-symptomatic spreaders. How far does COVID-19 relate to other major pandemias in mankind history? And looking at that, we have about more than 20 million affected and about 800,000 around the world. But comparing to other large epidemics going back to the 14th century and the plague, it's still much lower. The estimates are about 120 million people died at that time, and even during the Spanish flu in the 1920s, there were about 500 million people affected and about 50 million then died. So how dangerous is COVID-19? Looking at hypermortality, these is data from Germany. The red lines are 2020. The blue line is the moving average over the last 5 years. And you see there was a little bit of hypermortality for a couple of months in late March and early April. It's much higher in Italy, it's much higher in Spain, much higher and outlasting in the United States. In addition, a pandemic situation nevertheless raises a lot of problems in politics, philosophy, and sociology. And at the moment, the general impression is that we conceive it as sort of a narcissistic insult, that modern societies, despite of all the acquired knowledge, technology, and instrumental wisdom, cannot deal with a dumb thing as this virus. And all the restrictions imposed by politicians, of course, raise the problem of conflicts between freedom and responsibility, rationality and pragmatism, good and bad. And more philosophers also become interested in that. Professor Habermas, who's probably one of the most influential philosophers of our days, he just had his 90th birthday some days ago, and he was asked about his feelings about the pandemic, and he said there has never been as much knowledge about non-knowledge and the coercion to act and live under uncertainties. And that, just to briefly sum it up, we are dealing with a worldwide pandemic with a not really understood virus. We definitely know in the meantime that simple protection measures such as social distances, wearing masks, and avoidance of mass meetings definitely do reduce the risk of infection spread. This gives the consequence that in some sense we have to make a new driving license of our day-by-day life and accepting some sort of restrictions. When it comes to neurologic rehabilitation, I think it's important to know that for the classical targets at stroke and TBI, it is as important as it was before to do and go on with neurologic rehabilitation, probably with an extension into COVID-related problem settings. To do that, neuro rehab settings, of course, also need special security features. So thank you very much for your attention, but I want to alert you a little bit on the forthcoming 11th World Congress on Neurorehabilitation, held digitally between the 7th and 11th of October 2020. Would be happy when we come into discussion there again on these topics. Thank you.
Thank you, Professor Sveng and Hamburg, for those comments. We appreciate it. We're not going to have any questions right now, I don't think, Victoria. Is that all right?
That is all right. I think we should reserve the times for questions after the presentations.
Yeah, okay. So let's move on then to our first major presentation. I want to introduce Professor Lucia Braga. She's president of the SERA Network of Rehabilitation Hospitals in Brazil. This includes 9 hospitals with a total of 700 beds that treat almost 2 million people annually. I think that includes outpatients as well. She's considered a national and international reference for quality neurorehabilitation care. She was recently appointed to the faculty of the University of Massachusetts Medical School as a professor of psychiatry, and is engaged in neurorehabilitation studies in a number of European and American institutions. She has over 40 years experience working with patients with brain injury. In 2019, she was given the Distinguished Career Award from the International Neuropsychological Society in recognition for her sustained contributions to the fields of neuropsychology. She's on several editorial boards. She's published a number of books and book articles, and we're really pleased to have Professor Braga with us today. Professor Braga.
Thank you, Dr. David Good, for your very kind introduction. I will share my screen. Okay, today I will talk about telemedicine efficiency and satisfaction viewpoints of patients and medical professionals. Just a moment. We have no conflict of interest. COVID has killed over 1,023 million people. COVID-19 has killed over 1,023,000 people, in Brazil. Just a moment, I got a problem here. Just a moment, sorry. I got a problem here. Okay. The infection rate, oh, sorry. So I will begin again because I got some technical problems here. Vamos lá, Alberto. Essa tela que eles estão vendo, eu quero voltar para aquela. E aqui não estava aparecendo a minha tela. Ok. Let it go. Are you seeing my screen?
We can see your screen, and it did advance to the second and third slide.
Okay. Okay, then we continue. The SARA network of neurorehabilitation hospitals is the largest rehabilitation network in South America. It comprises 9 centers in different regions of Brazil, has 700 bed capacity, and sees over 1.8 million patients a year. SARA is funded by the federal government of Brazil, and there is no charge for any services at any of its 9 facilities. 2020 has brought many new challenges and concerns to our practice of medicine and rehabilitation. The whole world is dealing with the new reality caused by the novel coronavirus. As a result, we had to transform the way we deliver healthcare and rehab services. Most neurorehab patients have chronic neurological issues and disabilities that require lifelong follow-up. These patients are at elevated risk for COVID-19, but their treatment could not be suspended. They require ongoing assessment, care, and managing. So during the coronavirus outbreak, we developed a system of broad access synchronous telemedicine. From March to September of this year, we saw over 107,000 patients using our new system. This is how it's set up. The patient receives a text confirmation with date and time of appointment and instructions on how to prepare for the telemedicine consult, because many patients had never had this type of medical experience before. They can choose to have the session by telephone or video. Most have chosen video conferencing. However, since some do not have access to reliable internet or the devices required for teleconferencing, they choose phone consults. So we provide them with instructions on how to have a productive session with basic guidelines such as noting their questions before, having their medication list handy, choosing a place with privacy and light, no noise, etc. They are sent a link to the patient's portal, and moments before the session, they get another reminder, plus the terms of consent, which they must read and accept. They are also given a countdown to the start of the consult, with minutes and seconds left until it begins. For example, this appointment is at 8 a.m., 1 hour, 5 minutes, and 9 seconds away. At the scheduled time, the professional team logs on and adds the patient to the virtual room where the session takes place. The entire multidisciplinary team, 25 different specialties, which might include doctors, therapists, nurses, speech therapists, social workers, neuropsychologists, educators, and more, have started using this telemedicine system to see patients with chronic disorders who are at an elevated risk for the coronavirus. Here are some images of professionals delivering care remotely in various parts of Brazil, Midwest region, Amazon region, Northeast region, Southeast region, Midwest again, Northeast, Amazon, Rio de Janeiro, Southeast region, Northeast region, Midwest region, Northeast region, Southeast region, Midwest region, Northeast region. This was worked very well with all specialties across the country. Our system appeared to be very productive, but we wanted evidence-based confirmation. The main research questions were, Is telemedicine efficient? Are the patients satisfied with this model of delivery? How do the medical professionals rate the telemedicine system? The first phase of the study was focused on patient satisfaction and efficiency of remote healthcare delivery. We surveyed existing patients who had previously undergone medical evaluation exams and follow-up. There were patients of all age with different medical histories seen by various specialties at 7 hospitals. We developed a questionnaire with 4 main variables: efficiency of the consult, patient satisfaction with the experience, comparison with in-person visits, and where patients' needs met. Responses were rated and measured using the Likert scale. Between March and May, we had over 18,000 virtual consults, of which about 13,500 were invited to participate in the study. 2,433 patients or their caregivers responded to the questionnaire between April and May, which is about when community spread of the virus began in Brazil. We grouped the patient's diagnosis into broad categories: brain disorder, spinal cord, oncology, rheumatic disease, and chronic orthopedic problems. We used Spearman correlation and Pearson's chi-square for the statistical analysis. The results of this phase showed that 93% considered their experience with telemedicine to be efficient, citing that the practitioner listened to them, answered their questions, addressed their doubts, and provided needed guidance and information. Unexpectedly, the results were similar regardless of the patient's diagnosis, sex, age, hospital location, and specialties. This came as a surprise because we surveyed 7 different hospitals, over 25 specialties, and almost 2,500 patients with various medical needs. The satisfaction variable was also an important one. Most rated their experience as good or very good, again, regardless of age, diagnosis, hospitals, and etc. When compared with clinic and hospital visit, 85% felt the remote session was equal to or better than seeing the practitioner in person, another statistic that underscore how satisfied these patients were. Some existing elderly patients did not request telemedicine consults via our website, so our practitioners contacted them directly by phone to check on them and set up remote appointments. One of these patients gave us permission to show this short video of her.
Well, I have been Sarah's passion for the last 5 years. And as it is 100% free, you don't pay anything, but you get the most efficient attention in medicine care and also in all exercises like that. But now with the COVID-19, where we sit in our homes like birds in a cage, suddenly I got a call. It was from my physiotherapist, from Sarah. She was asking how I was feeling, what kind of exercises I do at home. You don't imagine what kind of soothing and grateful feeling one has in this moment. It is somebody is caring about you. So when the doctor called me again. I have asked him, how many calls do you do a day? And he said, 40 to 45 of depending of the length of conversation. It means that he gives the security feeling to 40 to 45 people a day. That means only he, but Sarah has so many professionals who are ringing to their patients. I will be all my life grateful.
In times of quarantine or in cases when patients are isolated by age or disability, having a live person on the other end of the screen or phone is an important component of what we do as healthcare professionals. After acquiring greater skill with the telemedicine system, we began using it to see new patients. The second phase of the study focused on the patients who had never been treated at our hospitals. During this period, we saw almost 600 new patients, of which over 300 responded to the questionnaire. Again, these are patients from 7 different hospitals across Brazil. We compared their response with those of existing patients. The first variable was, did the practitioner listen, guide, and respond to your questions? Over 95% of these new patients agreed that the session had been successful. Both new and existing patients equally rated telemedicine as efficient. This gave us confidence to continue seeing new patients with this modality. The new patients were also asked to compare their telemedicine session at SERA with their in-person experience at other hospitals. And a large percentage agreed that telemedicine consult was equal or better. These results were similar for both new and existing patients. In overall satisfaction, we saw that more than 96%, both new and existing patients, rated their telemedicine experience as good or excellent. Both groups agreed in satisfaction. We also studied if the needs of these new patients were met in the remote session. Since this was their first experience with us, we wanted to know how it went. However, overall, 97% of them agreed completely or partially that their health and neurorehab needs were met. 97%. Then the third phase of the study surveyed the professionals. How did they feel about their telemedicine experience? In their opinion, was it efficient? We invited almost 900 healthcare professionals and received over 650 responses. We compared the patient's response with the practitioners. The results were interesting. About 93% of patients strongly agreed that telemedicine session gave them what they needed, guidance, instruction, and care. But only about half of the practitioners strongly agreed that they were able to deliver. However, the difference is not statistically significant. Both patients and practitioners soundly agree that telemedicine is efficient. This is very important to the future of remote healthcare delivery. When we look at how patients and practitioners rated their telemedicine experience by comparing it with in-person sessions, 85% of the patients reported that they were the same or comparable Conversely, only 38% of the professionals felt this. The difference between the two perspectives is statistically significant. The patients rated telemedicine higher than the professionals did. Overall satisfaction, however, was equally high among patients and practitioners, but patients seemed to be more satisfied with a statistically significant difference between the two groups. Patients were more enthusiastic than we even imagined. This graphic shows the practitioners answer the question we posed. We grouped them often as in always possible. We grouped together often and always possible and asked their feedback on several topics. The practitioners reported that 95% of the cases they were able to instruct and inform the patients about their condition, activities, and necessary care. Likewise, they felt they could collect and share information and results with the patients using this system. This shows that the practitioners rated telemedicine as efficient for seeing patients with chronic neurological disorders. In other words, the system delivered the expected results. Most of the time, the team was able to tailor treatment and propose new modalities for the patients, showing that remote telehealth permits changes and adjustments to the management of chronic cases. The medical team did, however, point the difficulty in administering formal exams and tests, as well as physical functional examination. Even though the response showed that there were obvious limitations from professionals' point of view, we asked whether overall they felt that telemedicine was efficient and contributed meaningfully to the patient's treatment. 95% answered yes. There is indeed evidence of the efficiency and satisfaction with telemedicine in both practitioners and patients' experiences. These are very promising results that can help shape the future of healthcare practice, particularly among the population with chronic illness. The enormous systems we implemented was worth it, and we know that many other countries are facing similar challenges. Even after the current health crisis is under control, we might consider using remote telemedicine for neurorehabilitation for patients who either cannot or choose not to come to a clinical setting. COVID brought challenges to everyone, and those challenges are helping us grow in ways that expand our ability to meet the needs of patients everywhere. Thank you very much. Here is my email address.
Thank you, Dr. Braga, for a very exciting lecture and giving us a glimpse into the future, I think, of medical care. We have probably time for a couple of questions. I don't want to keep the schedule. Victoria, do you have any questions for Dr. Braga?
We do have a couple. We'll start off with, first, can you explain more about the teleconsult orientation packages for your patients? Was it just that text message? Were there brochures, emails prior to the teleconsult session?
Sorry, I couldn't hear you.
So basically it's asking, how did you orient your patients to using telemedicine? It's something that's new for a lot of patients. So what kind of information and how did you prepare them to be able to do that?
Yeah, we send text messages on the phone, explain how to do, how to use, and what they need for the question, for the session. We explain how to use the technology and how they should prepare themselves for the session, taking notes about the questions they have for the doctors, the problems, the medication list, everything. Then they are very well prepared, and some prefer do by phone.
Right. Next one, how did they assess the spasticity over telehealth?
How they access?
Assess spasticity.
This is the problem. To assess spasticity is impossible. And this is the problem the professionals were showing, we saw in their answers, because it's impossible to analyze spasticity or other physical functional exams. Then we need the consultation in person. I think always we'll need, but sometime maybe we can have sometimes in-person consultation and sometimes a remote consultation, avoid the patient to come to the hospital many times as they need lifelong follow-up.
Dr. Good, do we have time for one more?
I think one more, Victoria. Yes, please.
Right, one more. Were the majority of the patients outpatients or did you have inpatients?
We have also inpatients. The majority are outpatients. We treat 1,008,000 patients a year. The majority are outpatients, but we have 700 beds. And during COVID, we are seeing these patients, and now we are seeing also patients post-COVID for rehab. We are beginning to receive post-COVID patients.
Right, perfect.
Okay. Thank you again, Dr. Braga. That's very, very interesting, and we enjoyed your lecture. Let's move on then to the next lecture. Jorge Hernandez Franco is our next speaker. He's a specialist in rehabilitation medicine. He's the head of the rehabilitation department at the National Neurology and Neurosurgery Institute in Mexico City since 1991. He's regional vice president for Mexico, Central America, and the Caribbean for the World Federation for Neurorehab. He's a member at was elected as a member at large of the World Federation for Neurorehabilitation Presidium, and he's currently the treasurer of the World Federation for Neurorehab. He also has been president of the Latin American Neurorehabilitation Association. So his presentation is COVID-19 in Mexico, an opportunity for neurorehabilitation. Professor Franco.
Thank you, David, for this nice introduction. I'm going to talk to you about COVID-19 and an opportunity for neurorehabilitation, and to talk about COVID-19 from a different perspective. And in order to avoid technical problems, I suggest, Victoria, we go for the recorded version, and then I'll be open to questions and answers. That's okay with you, Victoria?
That's perfect. I'm ready when you are.
Yes, let's go ahead, please. Thank you. Hello, everyone. I'm going to talk to you about the effects of COVID-19 in the Mexican healthcare system. These are my disclosures. This outbreak has exposed many deficiencies in the Mexican healthcare system infrastructure, but I think we can look at it from a more positive way, from a different perspective. Every cloud has a silver lining means that there is not only hope in a difficult situation, but also an opportunity for a change. About 1 billion people experience some kind of disability worldwide, and 80% of persons with disabilities live in developing countries. Latin America and the Caribbean have a population of over 650 million people, and 12% of this population live with some kind of disability. According to data from 2010, disability rates range from 5 to 23% in Mexico. Mexico has 129 million inhabitants, half of them living in poverty. as shown in this map colored in red. Marginalized and forced to live from hand to mouth in overpopulated cities. And all these elements develop a vicious cycle between poverty, disability, and social exclusion, which limits their access to healthcare systems. The Mexican healthcare system is divided in two. On the left, you can see the two elements that compose the public system, which are the Social Security Institute and the Health Ministry Institute, and on the right, the private clinics, hospitals. Unfortunately, there hasn't been any communication between these institutes over the years, not even between the ones in the public area. And just an example to show you the poor foundation of the public system, there are only 250 rehabilitation facilities for the whole country. What's interesting is that after COVID-19, now all the systems are interacting and they're sharing patients, information, and equipment. So this is a very positive sign that shows that there's an opportunity after COVID-19. Nevertheless, inequality prevails, and as you can see on the left of this image, mortality is higher in public institutions, and it's almost 3 times higher than the private institutions, which are shown on the right, 15% and 12%. And while COVID-19 patients receive rehabilitation during the acute stage in private clinics and hospitals, public healthcare professionals demonstrate and demand the rights to have the proper equipment for just their daily work. The outcome has been a disaster. Almost 1,300 healthcare professionals have passed away in Mexico until now. And for the last 13 years, there has only been an increase of less than 400 hospitals. And due to COVID-19, during the last months, there has been some growth in hospitals. So this is also a positive sign. And regarding rehabilitation professionals, figures are low. There are only 2,250 certified rehabilitation specialists and 10,000 physiotherapists. The government is promoting education at this level and is providing scholarships. So this is another positive sign after COVID-19. And the way public rehabilitation facilities provide treatments are very inefficient. And this is probably due to the oversaturation of services and that they provide the therapy in groups. This not a very efficient way of providing therapy. And I think we have this makes the patients very dependent on the centers and on the therapist. We have to make them more responsible of their treatments. That's my point of view. Going back to the opportunity issue that I mentioned at the beginning of my lecture, the government has been forced to change its position in regard to the healthcare system. And there are 2 initiatives that I called the government initiative and another initiative, which is how we are going to change the way we provide rehabilitation in our facilities and where we work regularly. The government implemented what is called a community health intervention model due to COVID-19 and is now including the community in decision making, and also it's improving the relationship between the community and the health institutions. And I think this is a very good synergy that we have to take advantage and improve this way of providing rehabilitation in the country, which is community-based rehabilitation. Developing a less fragmented and more community-oriented system of care in disability. And hopefully reversing the difficulty to determine the prevalence of neurologic diseases in Mexico, and also changing issues such as the limited access of neurologists to rural areas or the limitation to provide exams, neurologic exams, to patients in rural areas. We also have to increase neurorehabilitation treatments in general hospitals and what we call in Mexico basic rehabilitation units, and not only have these neurorehabilitation treatments in very highly specialized institutions. Unfortunately, in these basic units and general hospitals, neurorehabilitation is provided also in a very inefficient way. There is a lack of use of functional scales. Treatments are not non-specific for neurological problems. And there are poorly defined goals in the treatments, which prolong inefficient treatments. And usually a non-rehabilitation professional provides the treatments, probably a nurse or a teacher. So we have to change this and make an impact in education, in the staff that provides rehabilitation in our community. Moving on to what I call the personal initiative, we have to make a smart use of our resources, and we have to be more flexible in the way we work. For example, we have to be more flexible in our schedules, in our working schedules, and also in the appointments for the patients, preventing the area to be oversaturated. Be more creative in the way we provide treatments, and also make use of low-cost technologies. We have increased a program that we've been providing for many years, which is a home program for neurorehabilitation. And we educate the patient and the carers and the relatives how to do the rehabilitation activities at home. Because I strongly believe that neurorehabilitation is a learning process. So the best way is to empower the patient and the relatives and care with the knowledge, making them more responsible for their treatments. In conjunction with this treatment, we used what is called the guided self-rehabilitation contract, which is in accordance with these guidelines, the guidelines that I mentioned before. And this was developed in France, and it consists mainly of passive stretching exercises and activity training exercises. And what we do is tailor the program to the patient's necessities, and we assess the patients regularly every 15 days, 20 days, and we change the program according to the improvement of the necessities, the patient's necessities. In my institute, there's a platform that has been used for many years for distance learning, distance education, and also for telemedicine. And now the rehabilitation staff will have access to use this platform in order to provide neurorehabilitation treatments and trying to reach more patients throughout the country. We're planning to do this with the help of smartphones. And in the near future, we hope to have the opportunity to provide our patients with a device that we developed with the help of a technological institute in Mexico, which is a very low budget virtual reality device, and we hope to provide this to the patients so that they can do some home neurorehabilitation exercises. In conclusion, the government is trying to get closer to marginalized communities, incorporating the community in the design of treatment strategies and including them with their knowledge and organization. And we definitely have to make an impact, not only in the community, asking them to help us in providing the treatments for the patients, neurorehabilitation treatments, but also trying to improve the way rehabilitation is given in neurorehabilitation facilities. We have to rethink the way we provide neurorehabilitation. In closing, I would like to underscore what our colleagues in Europe published in a paper that deals with neurorehabilitation and COVID-19. And I quote, "This emergency will produce long-term healthcare positive effects able to prevent or at least promptly counteract future outbreaks or their consequences." And I couldn't agree more with them. Thank you very much.
Thank you very much. A very interesting lecture. Both of these lectures have shown us that there are some positive aspects of the COVID pandemic that hopefully will go into the future, changes in healthcare, telemedicine that will go beyond the actual pandemic. So a very good lecture, and we appreciate your input and your insights. We have probably 5 minutes for questions. Victoria, do we have some questions for Professor Franco?
Well, we haven't had any quite roll in just yet regarding his topic, but let's just give folks a few minutes to see if they have any questions. But we do have some standing questions about telemedicine, and we could kind of shift and talk about telemedicine from Jorge's perspective and how that's particularly being integrated with virtual reality, because I thought that was particularly interesting.
Okay,
So,
sounds good.
yeah, what is it, that technology you had alluded to? Could you elaborate a little bit more on how that's going to work and how it could be scaled?
Well, yes, we decided to develop this kind of technology, low budget technology, in order to allow developing countries to have access to virtual reality therapy with looking for two main issues. One is to provide the therapy on patients that do not have access to this kind of technology. And the second one is to do some research also to prove that it works for instance, training for telemedicine. The virtual reality works with a gripper, and the gripper works with a laptop, mainly a laptop, and the camera, and it's just application, and they're allowed to work just with different games. The games were also developed in Mexico, like an hacienda or a rancho, and these games were developed in accordance to what we see the stroke patients are able to do. We developed these games in regard to what we've seen during our consultations on what the patients, stroke patients, are able to do, not asking them too much, and definitely not like an Xbox or this kind of games that demand too much on the patient. So we have already published 2 papers on this. We're about to publish another one regarding this virtual reality activities, and we're focusing now on motivation and the way they are attached to these kind of games, and we have very good results with this.
Next question. Are you already treating patients with neurological changes or deficits from COVID-19? And how has your experience been with these patients?
No, not yet. We're not looking at that now in our public facilities. We actually, in our facility, let me explain what happened in Mexico. What the government did was there wasn't enough hospitals to treat all the acute patients with COVID-19. So what they did, and I think this was a very smart way to do that, is to make an expansion of all the hospitals and allow some hospitals to remain just for the treatment of, gastroenterological problems or dermatological problems, but not neurological problems. But most of them turned to be just COVID-19 hospitals. And we didn't provide any, as much as I know, and some friends told me that work in these public hospitals, that they didn't provided any neurorehabilitation in the acute stage because they didn't have the proper equipment. Just as I showed before, just the private hospitals provided neurorehabilitation at an acute stage because they had the possibility to provide their staff with the proper equipment. And now we don't have any figures of how many people survived from this COVID-19 in regard to symptoms after COVID-19. So we're preparing now to receive, to get all these patients, and we're in the process of organizing the centers to receive all these patients. So I'll let you know the moment we start to receive them, to receive these patients, but not now.
All right, perfect. Before I ask the next question, I am going to launch the poll, and that's just to give us a little bit of information, demographic information about our audience today. So please feel free to fill that out. We'll leave that up for quite some time. But next question. So how is the situation related to the status of the patients related to COVID? And I think this is more about, is there enough testing in this population so that you guys can protect your hospital workers and your patients?
Just in the public hospitals, there are not many testings being done now, and the problem is that we're not doing much testing in Mexico. So only if you think that the healthcare professional has some symptoms or has been in contact with COVID-19 patients, the government encourages the healthcare professional to do some testing, and the public system provides the testing. But we're not regularly doing any testings, not even in the public system healthcare hospitals.
And maybe one more, Dr. Good.
Yep.
Do you do any rehab for people with cognitive problems in your institutions?
Yes, we do. Not only for COVID-19, but my institute, the National Neurology and Neurosurgery Institute in Mexico, we do that regularly, and that's part of the program. We do a very complete evaluation and treatment for neurological patients.
Okay. Thank you again, Jorge. Very nice. We appreciate it.
Very welcome.
Let's move on then to the next lecture. And please fill out the survey that you see as we progress now with the webinar. Okay, the next presentation, we're very pleased to have Mayawa Olabi here. He's a professor of neurology and professor of medicine at the University College Hospital in Ibadan, Nigeria. He's also the dean of the Faculty of Clinical Sciences at his university and director of the Center for Genomic and Precision Medicine. He's a fellow of numerous societies, including the Nigerian Academy of Sciences, the American Academy of Neurology, and the Royal College of Physicians. He's had many awards, too many to really list in this introduction. He's a member of the Presidium of the World Federation of Neurorehab. He's also the regional vice president for Sub-Saharan Africa. He serves as a peer reviewer for multiple journals. He's a member of several editorial boards. He has served as a member, as a mentor for postgraduate students and fellows. In the area of research, he's been an investigator or co-investigator on multiple grants. He's an author or co-author on over 250 peer-reviewed papers. His primary interest is stroke and neurorehabilitation, but he also is an epidemiologist and has published on public health funding. He's invited to speak internationally on many occasions, and it's a real pleasure to have him here to talk about the challenges and opportunities from Africa.
Thank you very much for that very kind introduction. So I will proceed to share my screen. I hope you can see my screen.
We can just throw it in presentation mode and you'll be good to go.
Okay. Okay.
Perfect.
Thank you very much. I hope you can see my screen.
Yep, it's perfect.
Oh, excellent. Thank you so very much. Well, it's a great opportunity to be invited to speak to this broad audience, live audience, and I'm sure this is also going to be on YouTube and many more people can watch over and over, and the interaction can continue. To speak on this very, very topical issue, COVID-19, which, like a dream, has shocked the entire world system. with implications that includes medicine, economics, sociology, philosophy, and everything. I really enjoyed some of the concepts and thoughts shared by Volker, by Volker on this. Yes, so the burden of COVID-19 in Africa. Africa seems to be the least affected continent. We don't know if this is completely for real, but it might be for real, or is it because of not testing enough? As of 25th of August, 2020, over 1.1 million confirmed COVID-19 cases were on the African continent. But out of these, more than 900,000 had recovered, with only 27,000 deaths recorded. There is also the African CDC. I must mention that even though this is a sudden challenge that has jolted the entire world system, it has also provided opportunities. As we know, challenges and necessities are the mother of invention. It has also provided opportunity to strengthen the otherwise extremely weak health systems on the continent, particularly the surveillance system and the disease control systems. So the African CDC and the Nigerian CDC have actually gained from this experience in terms of monitoring and preparing right now for the current epidemic and in fact pandemic, and also perhaps to prepare for the future. So there is the African CDC website which actually shows on a regular basis the number of cases that have accrued as well as the number of deaths and recoveries. And this keeps increasing. But when you compare Africa to other continents, you will see that Africa seems to be one of the continents or subcontinents that is least affected when you compare with the United States of America, for instance, or even with South America, Brazil and Argentina and some other countries there. Now, when you look at the graph in terms of cases, you would also see Africa is the one in blue, that the number of cases seems to be declining, not only in Africa, but in other places. Of course, initially, most of the cases were in Europe, and then America took over. And then there were cases in Africa, but even that seems to be declining. What is the reason for the relatively fewer cases in Africa? Is it just fewer tests? Or is it because of the high humidity and plenty of sunshine, which probably is a blessing in disguise that has reduced the impact or the ability to transmit or reduce the extent of the community transmission of the virus? It would have been a double tragedy if the virus was transmitted the same way it was in countries that have very, very strong health systems like USA, like Europe. If we had the same rate of transmission in Africa, it would have been a huge and monumental disaster. In terms of deaths also, we see that initially more deaths in Europe and then in America, but again in Africa, not so much. When you look at Africa also, the situation is not exactly the same across the continent. The heat of it, the brunt of it is being borne by South Africa, which has recorded more than 500,000 cases. And you also have Morocco as well as Egypt also bearing the brunt. And then in West Africa sub-region, I think Nigeria also bears part of the brunt. Well, these are some of the countries that have tested more than other countries. And so perhaps that's why we're having these numbers. But the situation seems to be fair and completely different from what was projected earlier on at the onset of the epidemic by the Imperial College of London, Imperial College in London, that we would expect more than 392,000 deaths in Nigeria. But so far, as of yesterday, we have only a little above 1,000 deaths in Nigeria. So completely different from what was projected. In as much as we may say, oh, perhaps this is underrepresented, but again, in terms of death rates generally from the country, we are not really seeing a spike that we can attribute to COVID-19. So in terms of testing, The countries that have tested more have been South Africa, have been Ghana, have been Morocco. And then, of course, in terms of deaths, you see that Algeria, Egypt, South Africa has borne the brunt of deaths on the continent. Now, in terms of the healthcare systems, Africa has a very, very weak, sub-Saharan Africa specifically has actually, I would say, the weakest health system globally. And, we do hope that this is going to improve. Of course, also in terms of neurorehabilitation, both in terms of demand, supply, availability, awareness, it's also at the lowest ebb. Of course, we've been trying very hard, and I think we're getting some results to raise awareness about neurorehabilitation on the continent. This is yielding some fruits, and to see how we can incorporate and integrate neurorehabilitation services, training, and research into the healthcare system within the continent. But looking at the healthcare system within the continent, the weakest healthcare systems are found in countries like Nigeria, like Mali, like Congo, like Ethiopia, Madagascar, and Somalia. And of course, if we were to be hit by this epidemic or pandemic, the way it has hit other continents, these countries are going to really bear the brunt of it. So there are peculiarities of COVID in Africa. One of it, of course, is like we said, perhaps there is some level of protection due to environmental factors, which has limited the number of deaths, at least. Perhaps we even have a high number of cases, perhaps even up to 30–40% of the population are affected already, and perhaps there's already some herd immunity. We need to really get some data to back this up. But in terms of deaths, it looks like that is relatively less. Now, there are challenges in Africa, even in Nigeria and other areas where there are conflicts, Mali and some other places. And we were really, really, really scared when some cases were reported in the internally displaced camps in areas that were affected by Boko Haram crisis in Nigeria. And of course, you know, in those places, in those camps where you have internally displaced persons and refugee camps, it's almost impossible to maintain and, in fact, to ensure that all the rules in terms of limiting transmission, be it regular hand washing, be it physical distancing, be it wearing of face masks, are almost unimplementable in those places. And we were really scared. That's one of the challenges of those vulnerable population in an already very, very weak health system. And of course, again, it's very difficult also to reach those areas with healthcare providers because of access issues and security issues. In fact, Africa is the place where we experienced a very, very massive interplay of this very, very important balance, fragile balance between maintaining health, security, and economy. Initially, a few of the African countries, I mean, the responses were completely different across the continent. Initially, a few of the African countries really rushed to impose lockdown, but it was biting harder and in fact leading to security issues because people really did not have any support, and people who are staying at home, and a lot of people who are just small and middle income, medium scale industries or workers. Once they don't go out, they don't have any income, then they cannot even eat, let alone have access to healthcare. So, and that led to some security issues, and the lockdowns had to be relaxed over time. So this really played out quite well in Africa, but we were very lucky, really, that the death rates that resulted from this were not really that high compared to other countries. So damage to international crisis management and conflict resolution mechanisms due to travel restrictions in places like Mali and other African countries. Those are some of the impacts and peculiarities. Now we know that COVID-19 shocked the entire world, affected the entire world system, but also COVID-19 is a multi-systemic problem that affects all the entire system within the human body, particularly the vascular system, but also the brain and the central nervous system and even the peripheral nervous system. But the brain, of course, is of particular interest, and we know about the cytokine storm. And recently, using artificial intelligence and the world #2 supercomputer, it's been found that there is another hypothesis, very strong hypothesis, the bradykinin storm, which if pursued might actually yield new interventions. Of course, we know about interventions such as use of steroid, dexamethasone, and also anticoagulants, which we've actually used, and that has actually saved the life of some patients. In fact, there is a particular isolation center in Ibadan where there was no record of deaths was recorded in those who had COVID-19. But of course, within the University College Hospital, we've recorded some deaths, but some people really did well when they were given, or the outcome was a little better in those who got dexamethasone and anticoagulants from the onset. So, well, encephalopathy, encephalitis, seizures, delirium, dizziness, of course, in the setting of comorbidities. These are all the mechanisms underneath. Stroke and COVID have a very, very important relationship, and both ischemic as well as hemorrhagic stroke have been attributed. And in fact, there is a 5% increase in the risk of ischemic stroke with COVID-19, according to the World Stroke Organization. And the severity of ischemic stroke is actually more, and in fact, any other health condition is more when combined with COVID-19. For ischemic stroke, the mechanisms include hypercoagulable state, vasculitis, cardiomyopathy, and then secondary hemorrhagic transformation can occur. As we know, the COVID-19 virus targets ACE2 receptors in the endothelium and damages the vessel wall and can lead to rupture. And that's one of the mechanisms for hemorrhagic stroke. But beyond that, it can also lead to posterior reversible encephalopathy syndrome, PRES, and the cytokine storm, or right now the bradykinin storm, may lead to necrotizing encephalopathy, encephalitis, and so on and so forth. So quite a plethora of mechanisms that could be targeted that could lead to all different types of stroke. Now, in terms of research work, well, very, very few research work on COVID on the continent. One of the reasons may be because, perhaps the number of cases are really not that very high. Perhaps access to testing also not good enough. But a few case series like in Tanzania show that those who have comorbidities are likely to die more, which has been seen elsewhere. And then this is just in Ghana, just looking at rates of admission of stroke cases. After the lockdown was eased in Ghana, of course, the hospitals were flooded with a lot of cases. And in fact, the number of stroke cases was higher within the period of January to June 2020 compared to January to June 2019. Perhaps there was a spike in cases as well as fatality. So now, what is the impact of COVID-19 on neurorehabilitation on the African continent? This is actually the main aspects of this lecture. Well, the truth is that this varies from place to place. Initially, during the period of lockdown, what we observed is that people were really very scared. They were not willing to come to hospitals. Neither the patients nor the caregivers were willing to come to hospitals because they were afraid of contracting the virus. So there was a lot of non-presentation, or in fact, delayed presentation when the patient is almost dead. That's when eventually they come. So this was found in different places. But later on, when the lockdown eased, even when the transmission and the number of cases was increasing, I think the fear for the virus was reducing, and people were then presenting more. And when they were presenting more, again, there was increased pressure on acute care services as they competed with neurorehabilitation cases, competed with COVID cases for acute care. Same thing for rehabilitation, COVID cases, compared for hospital beds, compared with those who needed rehabilitation services. So it then became very difficult providing even outpatient care, also difficult because patients were not coming. And even staffers also, although in some instances they were still able to come, but the restrictions also affected them. Therapists were also affected by the restrictions. So, and therefore, even home-based care, due to movement restrictions, was also not very good. So, neurorehabilitation introduces a lot of chances, increase the chances of, I mean, particularly when you are delivering therapy or physical face-to-face consultation, examining patients, or you're taking blood samples or doing some tests, it increases the chances of contact. It's difficult to do that with physical distancing. And so that's one of the reasons why the chances of picking it up or transmission, unless you adopt telemedicine, is very high when you are taking care of patients. So of course you need to do all the others, make sure frequent hand washings and use of hand sanitizer, use of protective N95 face masks, all of these you have to try to obey as much as possible, and physical distancing and spacing out appointments, both in terms of time and even in terms of the number of patients that come at a particular time to use a facility. So all of these are really very important, and were even imposed in other public places like banks, like hotels and all that. So prolonged and close interaction is usually required, and that is one of the reasons why there could be increased chances of transmitting COVID-19 virus in the setting of rehabilitation. Then it is particularly difficult to communicate with some patients who need neurorehabilitation, particularly those who have cognitive difficulties, in terms of telling them about the COVID-19 prevention protocols, like wash your hands frequently, cover your face, and things like that. That may be very difficult. And then there is a frequent need when a patient is coming to seek neurorehabilitation care, attention. They are usually accompanied by their family members. That increases the number of people and the density of people, and therefore perhaps also the risk of transmission. So what are the steps to limit transmission? Of course, early and preventive identification of symptomatic cases. You can triage cases either by phone call, video call, telemedicine, before asking them or even booking them for face-to-face contacts or treatment where that may be necessary to establish the diagnosis or to run some tests or to assess the need for different forms of therapy, or even to initiate those therapies and then see how you can continue them on outpatient basis or even remotely using teleconsultation or telerehabilitation. Then physical distancing measures and compliance. You need to really completely reorganize the setting where the service is provided, and this is what we've been able to do in different places across the continent where the services continued. Personal protective equipment had to be procured, and of course you need to work very, very closely with the surveillance units, both within the state government, the local government, as well as the national government and Africa as a continent as a whole. Then you need to reduce hospital stay as much as possible and as much as is appropriate. Early discharge as appropriate. Communication with and support for the patient and caregiver. Psychological support is extremely important because of the fear and the anxiety and the psychological stress and distress that have accompanied the epidemic, coupled with a lot of economic distress as well and social distress accompanied it. As of 14th of August, it was 6 months since Africa had its first case. What have we seen on the continent? What we've seen on the continent has been just a gradual rise, not the sudden rise or surge, exponential surge that has happened in other places where within 2 to 3 weeks of their first case, there's exponential surge. This did not really happen on the continent. What have we seen? Initially, capital cities were affected, but then, and of course, lockdowns initially prevented spread to rural areas. But now we, of course, have these affecting rural areas, suburban settlements, and areas where there are lower population densities. What are we seeing in Africa? It looks like it's going to be a marathon, not a sprint, with multiple local outbreaks because many different communities recorded their first cases at different times. So they will have their own patterns and peaks at various times. But the good news is, according to WHO assessment in August, 16 countries in sub-Saharan Africa have improved their capacity because really it was an opportunity to improve capacity for disease surveillance. So for coordination, for surveillance, laboratory capacity for testing genetic testing, case management, infection prevention, and control. And I think these lessons that we've learned is likely to linger on. So what have we learned from this pandemic? First of all, it was a shock to the entire world system. It was a completely, novel virus that shocked the entire world system to its marrow. It was unexpected, unpredicted, even though some scientists have predicted that this is going to happen with, based on the interaction between bats and humans in China and in other places. And this again draws our attention philosophically to the One Health philosophy, that we need to really, if we really want human health, we also have to think about the One Health philosophy, health for the planet, health for other organisms within the ecosystem of the planet. What have we observed? Relatively fewer cases in Africa. Seems to be abating in terms of number, in terms of death rates. Is it because herd immunity has been achieved in Africa higher than other places? Not really very sure. But it's possible that there may be another wave and another wave and another wave. There may be multiple peaks, so we don't necessarily need to lower our guard yet. It's an opportunity to strengthen telemedicine, telecommunication, tele-rehabilitation models in terms of diagnosis, assessment, patient education, particularly through social media. I think this is very important in terms of prevention and so many other things. An opportunity to provide support through telecare to the caregiver and to the family. An opportunity to strengthen task sharing with families and with caregivers. And this is going to linger on. But also at the same time, we need to draw the line and determine those things that still require face-to-face physical consultation in order to be able to deliver the best and the very best for our patients across the continent. Thank you so much for this opportunity. Thank you.
Thank you very much, Dr. Awolabi. Really appreciate that. He showed a picture of the Blossom Center here, which
yes,
is
thank you very much.
And it's
very much.
Place. I visited it and I was very impressed. So again, thank you for your insights. Victoria, it looks like there are some questions for Dr. Awolabi.
Yes, we have a couple of questions. So first, what is the incidence of post-COVID stroke in the African population?
Okay, all right. Post-COVID stroke, in terms of incidence, like I said, one of the things about Africa is that actually we don't have a lot of data. I think we should mention that. But I must also mention that even though, for instance, the stroke incidence study, the very first stroke incidence study on the continent was conducted about 5 decades ago, and it was led by my university, a late Professor Shuntokun. The only other very good incidence study that we have on the continent, based on real data now, not based on GBD models and projections, was in Tanzania in 2006 by Professor Richard Walker. But we just got very lucky with a lot of hard work to get funded for a rigorous e-surveillance-based, mobile health-based stroke surveillance study, incidence and prevalence on the continent, which I'm going to be leading. Is going to happen both in a rural as well as urban setting within Nigeria, and it will be a model for other countries on the continent to use e-surveillance or mobile health for surveillance of stroke cases. So, in terms of actual incidence of incidence figures per 100,000 populations, I would say we don't have that. But like I mentioned in the case series, we've had quite a number of cases of stroke that were COVID positive. Now it's difficult to say whether they developed stroke because of COVID or because most of them really had other comorbidities like hypertension, like dyslipidemia and diabetes mellitus. And of course, the fatality rate was higher. So yes, there were a number of cases, but we don't have actual accurate figures per 100,000 population. Thank you very much.
Okay. Do we have time for one more?
Yes, please.
All right. Have any tests been done on ACE2 genotype polymorphisms in African population to explain the less number of cases?
Okay, I know that a lot of studies are going on, maybe not conclusive yet. Complete sequencing, really, of the virus, of at least some cases in Nigeria. And I think that's actually even the first to be done in Africa. There was complete sequencing and characterization of the viruses in Africa, I mean Nigeria, and they were able to trace the first case, I think, that came to Nigeria was actually from Italy. Was from Europe. So the virus has been characterized. It doesn't really seem to be completely different from what you have elsewhere. I think we might just have been lucky in terms of the high humidity and then sunlight. Of course, we know ultraviolet rays rapidly destroy the virus. So I think we just have been lucky in terms of the environment, because like I mentioned, even if we were not as lucky as we've been, it should have really been a major monumental disaster. Like in Nigeria, for instance, 350,000 deaths was projected, and we've had only about 1,000 deaths. So I think we would just say the environment maybe has protected us rather than other things. Of course, it's important to also study the host factor as well as the virus factor to be able to know why we seem to be less vulnerable. Thank you very much.
Again, thank you very much. We appreciate your insights, and we're going to go on now, I think, to the last lecture. I'd ask all of the speakers to at least remain available in case there are some additional questions at the end of the webinar. And we're writing pretty much on time, so we should have time for some panel discussions at the end as well. So I'd like to introduce our last formal speaker, Nirmal Surya. He's part of the Surya Neuro Center in Mumbai in India. He also is affiliated with the Bombay Hospital and the Saifi, I hope you pronounce that, hospital in India. He's the founding president of the Indian Federation of Neurorehabilitation. He's also president-elect of the Asian Oceanic Society for Neurorehabilitation. He's an executive member of the Indian Stroke Association. He has many different awards. He's a member of many different societies. It's quite impressive when you look at his CV. I want to point out that he was president of the 10th World Congress for Neurorehabilitation in Mumbai in 2018, and that was much appreciated. And of course, the next one is going to be next month, virtual Congress. He's also chair of the Developing World Special Interest Group of the World Federation of Neurorehab. He's frequently asked to speak nationally and internationally. He has many peer-reviewed publications, and he's on several editorial boards. And I think we're going to enjoy his presentation with the experience from Asia. Professor Surya.
Thank you, Professor David. Good evening, friends, and thank you to WFNR Presidium for having invited me to speak on the problem which we all are facing at the moment. You all are aware that India is third in the list with 3.85 million people suffering from the COVID-19, which is also just behind the Brazil. However, the recovery rate is about 70 to 80%, and we only have 67,380 deaths so far in India. But what is more important thing is that I live in a city which is Mumbai of Maharashtra, and Maharashtra alone has 808,000 patients with 26,000 deaths, and Mumbai contribute to 50% of the Maharashtra. So Mumbai, the place we are living in, has been very, very difficult for past 6 months. It is only for past few days that we are getting better. I'm going to speak about how we have worked in pre-COVID era, and then from March to May, and then May to July, and August onward. So initial fear, helplessness, did not know what to do, then slowly getting adapt and started looking at new things, etc. So my talk will be on the following 4 phases, and I'm going to talk how we cope with in India and in Mumbai. There are some facts to share. We all know that Asia has 80% of the problems, 85% of the population, and China, India, other Asian countries, Sub-Saharan Africa, and these are the developing countries which are the problems. And their problem is poverty, malnutrition, which result into many disorders unique to this region. They rarely attract attention and priority in cramped health budgets. And research takes a very back seat. And there is a vicious cycle which has been talked about by all colleagues in before, that how there is a limitation to perform economically, which leads to decrease in income, deterioration in living standard, reduced income, poor housing, and then this become a vicious cycle which put them into down and down and down. So what are the rehabilitation services in Asia and the developing world? There are very small number of specialists which are trained, and in many places they do not even exist. And therefore the orthopedic surgeon, physical therapists, they are the one who are running the department of rehab medicine in many places, which is of course is improving at some places now. So it addresses only certain part like exercise, mobility, gait training, use of gait aids, but other part of the rehabilitation are really not been addressed. And in some cases they give false reassurance which are given regarding outcome and prognosis, and therefore the patients are very unhappy at some point of time. And this is the reason that many patients in developing world do not have access to adequate and appropriate rehab services necessary for community reintegration, even though initial surgical has been done adequately. So in rural area, there's another problem. There is access to services and facility, lack of infrastructure, support, lack of understanding among healthcare, poverty, illiteracy, absence of inadequacy of statistics. And 70% of people with disability in Asian and Pacific developing countries live in rural area, and access is the big problem. Talking about India, 1.25 billion population, second after China, 70% lives in rural area where agriculture is the main problem. Cities have modern amenities, private setups, but villages have poor facilities. Again, therapists and osteopaths are the one with alternate medicine people who lead the role. Neurorehabilitation specialists are very few. Yoga, Ayurveda, Surya Namaskar, etc. They help people to maintain their physical fitness. India has 6% of GDP for total health expenditure, and private healthcare expenditure is about 4.25% of the GDP. There are many other systems like Ayush, that is Ayurveda, Unani, homeopathic. They also form part of the healthcare system in India. And if you look at the neurologists in the country, there are about 2,500, with PMR specialists about 1,000. Therapists are the largest number, about 45 to 50,000. OTs are about 20,000. Speech and language about 35,000. But neuropsychologists are only in few hundreds, and we do not know about the osteopaths and others. So every day the qualified specialists from India and therapists are moving out of the country. So there is a brain drain. So there is an unmet need and supply, which is there's a huge gap. And individual trained therapists, either they are in urban center, rural center, or home-based, who are the one who take care of the thing. These are the therapists, various therapists, PMR or OT, or the physical therapists, and density of prosthetic and orthotic available from the WHO report across the Southeast Asia. And you could see that there are very few trained people available in Southeast Asia. So again, going to now COVID, when we started in March 15, when India, 12th March, the Prime Minister declared that there is a complete curfew, nobody will get out. There was a fear, helplessness, did not know what to do. And you could see that the highways are empty, the trains are empty, and trains have stopped. This was Mumbai, which is never seen. So that was the problem. And this was the paper which came, that Neurological Association of COVID-19, and we started understanding that probably the neurological problem is stroke or Guillain-Barré syndrome or the fatigue and the anosmia or agusia. So we started looking for those patients in our population who are getting. And if you see the number of patients who were coming for rehab, say in January, February, mid-March, they started falling down to 0 in April because everybody was at home. And now it's slowly from August again picking up. And these are number of the patients which are shown. So in patient rehabilitation, we develop a positional statement by an IFNR that how we are going to do the confirmed patient. We are given A, B, C, and category, D category, that who are the patient who should be treated, how they should be treated, what are the various requirements has to be done. And we also gave a statement for the outpatient patient, like rehab program must identify the goals, should be planned as much possible as hand-free. And if there is not possible, there should be sufficient protection, because we didn't know what are the protection required, only mask, gloves or gowns or what else, PPE completely. And patients who are conscious and cognitively sound should be involved in active exercise in form of functional or task-based training. Preferably family-based rehabilitation must be encouraged, and tele-rehabilitation should be used as follow-up, and we should train the adequate education, etc. So in practice of neurorehabilitation, what we observe is 35% of patient service was reduced, outpatient was reduced to 20%, tele-rehabilitation was increased to 80%, which was 0, and there are 18% of patients who had no treatment whatsoever. And this paper was very interesting, which is factor affecting the rehabilitation to the individual and also the factor affecting the healthcare system, which was seen. So what we did, we started thinking that what should we do? And during the April first week, we started education during COVID-19 pandemic. And we have many international speakers. Here is the Professor Barbara, Professor Alessandro, Professor Jude Casselring. So we did a series of training on the webinar. So first was on 4th of April, which was on stroke rehabilitation by me. And we had really 1,500 people on the Zoom and who were part of it. So we saw a phenomenal response. We opened the Zoom and it was closed in 10 minutes. And we got feedback from 427 people, which are multidisciplinary. So we continue a series of webinars starting from 6th April to 5th May. And you could see that some of the webinar has, and then second time we started YouTube Live from the 7th April. And you could see that there are nearly 5,000 people attended our webinar, and which included all the possible topics starting from stroke to the speech and language, cerebral palsy, Parkinson's disease, TBI, stroke and TBI, and then music and aqua, MS, scales, palliative care, rehabilitation, spinal cord injury, vestibular rehabilitation, optimizing botulinum toxin in neurological condition, neuropsychological rehabilitation, spasticity, botulinum toxin, language, cognition, motor neuron disease, neuroplasticity, early intervention, and the same way ADHD, LD, aphasia, and then peripheral nerve and neuromuscular rehabilitation. Again, music therapy, and what are the research by Julie Bernard, bladder and bowel, early detection of dementia, dementia care, autism, pain management, and hyperbaric therapy, and cerebral ataxia and peripheral neuropathy. So we started the main thing, and what we observe is that second half of the April and first week of the May, there are so many other people started webinar and the numbers started falling down. So we said we involved the young students and we started IFNR case discussion on the net, that is Icon. So every Friday, again, 2 hours, we had case discussion, and which was very well accepted. Young students, therapists, they were the part of it, and we nearly had 300 plus audience in that. So after 6 series, we now focus on having a very systematic courses, which we have every week for 2.5 hours for 4 weeks. So we had first IFNR basic gait analysis course, which was done for 4 sessions, 2 hours each on normal gait, 3D instrumentation gait, pathological gait, practical approaches, and there were 89 delegates at 20 faculty. So we will only register less than 90. So, less than 100 was the target. And then second we did was spasticity management course, which had 88 attendee and 21 faculty, again lasting for the 4 weeks, 2.5 hours each. And upcoming is stroke rehabilitation course, We start on 11 September and we'll go till 2nd October. We already had 81 registration for this course. So these are going on well. The delegates continue to have discussion on Telegram group, which continue to have their cases every day, even in between the lecture. So it is a two-way definition going on. So what we did is we had a feedback from all the students who were, all the attendees who attended. And in first phase, we had 715 people. There were people who were from outside country, and you have Australia, Austria, Bangladesh, Bhutan, UK, USA, Ireland, Saudi, Nigeria. So there are many other countries beside India who has attended, but out of 4,715, Indian were 3,891, and Maharashtra and Gujarat were the leader from where the maximum number of attendees were there. And since India had large number of therapists, the 40% of them were physiotherapists. And when we asked them how useful they were having this webinar, about 80 plus percentage, about 86, 87 said this was very useful. And did you receive adequate information? 85% said yes. And then would you like to attend the e-conference training courses? 98% said yes, they will be. There was no doubt about that. And we also asked whether the question answer session, etc. were proper, and most of them were satisfied. And how would you rate the overall webinar organized by IFNR, IN under the WFNR? Again, most of the people were very satisfied. So we went again and assessed the part 2 webinar, where 10,894 people gave the feedback. And you could see that average feedback was about 500 to 700 people in each webinar. And again, we had out of 10,894, 10,256 people were from India, and rest all from many other countries, including the USA as well as UK. And again, 45% people were from physiotherapy. And most of the people think that webinar was very useful, and they were satisfied with the question answer, and they received adequate information, and they would like to attend the future courses. So 98% people have no doubt that they wanted it. And overall webinar, they gave a very good rating. So this gives us the idea that there is a great need of neurorehabilitation education, not only in India, Asia, but all across the world. And we again come back to that. So from May to July, we slowly started adapting. We got a new idea from other people. So Italian people experience came to us. We learned from them. We started digitalization, telerehabilitation guidelines. India made the guidelines in late March, and we started working on that. And we started getting safety gears built up in our own country, which used to be very expensive, started coming that cheap, and everybody has started having that. So we got more prepared. So we did a neurorehabilitation survey on during COVID-19 pandemic India, how they feared about this. And then 853 people responded out 872. And this was from all over the country. And most of them were from urban setup. And they thought that neurorehabilitation education is adequate in your field curriculum. Only 46% felt that their curriculum was adequate. Rest all people thought no or maybe. And would you like to receive more training in the field of neurorehabilitation? Again, 95.5% said yes. And when we asked, would you be interested in enrolling for any training courses organized by IFNR or WFNR, say for 1 week, the 600 plus people out of 800 had said yes. 1 month is nearly 50%. And then even for 1 year, there were nearly 50% people said we would be wanting to learn more. So that's very interesting thing which came. And then when we asked during the lockdown due to COVID-19 pandemic, what services are being provided at your center? And you see that emergency was the 50% and telerehabilitation was another 50% people who said, and that's elective was very less, and the new patient was again very less. And we asked them, what are the protective measures you are taking? So most of the people, about 60% were using surgical masks, gloves, or hand disinfectant. Full PP was only 12%, and 12% has none. And we again asked them, how often do you visit your workplace? 61% said we are staying at home. And then there was some would said that daily we are going half day, rest were once in a week. So there were very few people who were actually going for rehab. And mode of treatment during COVID-19 pandemic, again, the tele-rehab was the main, and no treatment was also important, as I mentioned to you. So what are the main concerns raised by the rehab professional was availability of PPE during treatment session, close proximity with patient while treating, duration to treat one patient with minimum risk of infection, but there were no clear guidelines, 20 minutes, 10 minutes, half an hour, whether cater to inpatient or provide outpatient service also. So these were very few issues which everybody has in their mind. And recently few hospitals started. So August onward, as most of the hospitals started rehab services, the response of patients was poor due to fear as well as non-availability of transport. Like in Mumbai, the local train is not there. So people have to pay a hefty amount to come by taxi. So they avoid. And in this testing time, teleconsultation and tele-rehabilitation has been started by most expert, most hospital who do not have access to the personal rehabilitation. So this was a consensus statement which we, as a part of Indian Stroke Association, we gave, and I wrote about the rehabilitation, which is likely to be suboptimal in pandemic time. We can provide very limited guidance to stroke team at this time, and this came in April. So this was April that we gave routine therapy should be avoided, and we said PPE, etc., has to be given, and all that recommendation has been changed for those non-COVID as well as for the COVID has modified again as we go from April to the August. And also we had, I was part of the chronic neurological in COVID era, this consensus statement which was published in Frontier, where we wrote about, because chronic neurological problem is the one which require regular rehabilitation, and we wrote about the PPE, etc. use and how they should be handling the rehabilitation in these patients. I looked into the couple of things, and other people around my country like Bangladesh, we could got that they have some problem. And again, out of 20 institutes there, the 15 had no rehabilitation, and there the rehabilitation has been severely impacted, and recommendation they provided to keep the pandemic contained while providing adequate and standard rehabilitation services as per the WHO guideline. About the Sri Lanka, we could not get what are the various rehab action they have taken, but they came out with a wonderful telemedicine protocol, and telehealth is what they have made a beautiful protocol to treat most of the disorder on telehealth. The issues are neurological disability, which is non-COVID, requiring regular rehabilitation. They are the one who get most affected. There are persons with neurodisability and who get COVID, they are in the hospital, they are at least being taken care and given the long-term treatment. And then COVID-related neurological complication needing rehabilitation. And what we are seeing now is GB syndrome after the COVID, and we are seeing many cases of Bell's palsy and peripheral neuropathy. I at least have seen more than 20 cases of Bell's palsy post-COVID in 3 to 4 weeks time, and they require regular therapy. And good thing is they have antibodies developed, so there is not much of fear to treat them. This was one interesting study which shows that there are 60% patient has negative impact on mental health. They reported a worsening of depression and worsening of anxiety. So that's what is the fear. Indian Academy of Neurology has published a viewpoint journal, and there we have consensus statement on various recommendations of acute stroke. I already told you MS and related disorder, and then what every neurologist should know, managing migraine, neuromuscular manifestation, epilepsy, etc. One can go into the detail on the annals of Indian Academy to get all these features. We also are part of the Neurorehabilitation webinar organized by Chile Group in July, and it was very interesting how Neurorehabilitation, which was unknown before March 20, even in India, has become a main feature. There's an increasing awareness on neurorehabilitation, which lead to more utilization of tele-rehab. Low-cost cellular data services, which give an opportunity to make it an integral part of the follow-up services. We need to infiltrate it to already existing government program, and Government of India has been very proactive for telemedicine, and I'm sure telerehabilitation will become part of it. We at an Epilepsy Foundation, which I run as an NGO, we have developed a service model which can be a lead for other organizations to follow, which not only treat the epilepsy, but treat the epilepsy with neurodisability. And future is digital in neurorehabilitation in developing country. So COVID-19 pandemic has changed the way we are going to practice in the future. And this was one of the paper of family-based rehabilitation. At that time, it was not the COVID when it was published, but at that moment also I said family need to be trained with telerehabilitation, which could be a good combination to treat the people with long-term chronic neurological disorders. And these are some of the guidelines and feasibility and challenges on the telerehabilitation, which is published in India. So this was a paper which we published in July, comprehensive epilepsy care during the lockdown due to the COVID-19 pandemic in India, Epilepsy Foundation India model. Besides the consultation, you have yoga, counseling, cognitive therapy, physiotherapy, occupational therapy, and art and other training therapy. And these were all live on the Zoom. You could see that people were, the people who have never ever been on the telephone, they started buying the smartphone and learning how to connect on the Zoom and how to behave. And this was the patient we treated about 168 for the consultation, cognitive therapy 50, yoga 142, and psychologist counseling by 38, physio OT by 53 patients, and telephonic consultation on WhatsApp to the 58. And these are the model which we have formed. And these are the problems which patient has, challenges which patient has faced during the COVID time. And these were some of the discussion which are already written, that people have increased seizure, fear, and additional stigma associated with COVID, and emotional stress associated with secondary to lockdown. And even music therapy, where the children started learning the music from the trained teacher who are also an epilepsy patient, has helped out to the people. And we also assessed the quality of life of the patient with epilepsy in COVID pandemic. And we assessed about 100 patients in 3 months period, how 3 to 4 months, how they have worked. And 69% patient had no seizure, but the 31 patient has either seizure one or more, on that they may be due to the missed doses or due to the stress. And what you also felt that patients were more worrying about the seizure, sitting at home. Many of them were feeling that they may not have the medicine availability. And that's the reason we wrote to the government to allow the pharmacy to continue the medicine on old prescription till they see a doctor or get a digital prescription. But that has changed. So these were some of the assessment which we were able to do and help out the people. This was the WHO landmark paper, which you all know, which has guidelines for everybody, that rehabilitation improve the health outcome of patients with severe cases of COVID-19 and benefited health services too, and the impact of rehabilitation cessation or the reduction on patient outcome, and the impact of rehabilitation service delivery, etc. To summarize, COVID-19 has made a great impact in the life of people with neurodisability, whether acute or chronic. Initial fear and helpless in the mind of patient and therapy giver is slowly moving into acceptance of situation. Teaching and training online has been a big plus point of the helpless situation and boon for many students and young therapists across the globe, emphasizing the need of structural training in neurorehabilitation around the world and Asia. Long-term therapy may be slowly replaced by telerehabilitation and family-based rehabilitation. Everybody needs to adapt. Tele-neurorehabilitation is future. WFNR, AOSNR, and IFNR should join hands to develop low-cost therapy-based app to be used by many in limited resources country. Post-COVID-19 era will be different in many aspects of life, and so will be the neurorehabilitation. Thank you very much. Namaste. This is ICF Neurorehabilitation webinar, which will be on Saturday Indian time at 1 o'clock. Professor Matilda Leonardi has agreed to speak on ICF in rehabilitation of neurological disorder. So that's something which is coming up in next 48 hours. Thank you very much for your patience here.
Thank you very much, Professor Surya. Very interesting presentation, and you point out very nicely how the COVID epidemic or pandemic is changing the way we practice medicine, the way we educate ourselves. It's quite amazing, actually. And many of these things are, I think, really very, very positive. We are almost out of time, but I think we have a couple questions. I don't know we'll have time for a panel discussion though, but at least a couple questions and some information about continuing education needs to be presented. And then can we find out who the participants are as well? Victoria?
Yeah, absolutely. So let's start with some questions. First question, would you say this is the right time for a consensus statement on neurorehabilitation in India, especially endorsed by the Ministry of Health as well as the Ministry of Social Welfare?
Absolutely. I think we are now aware that how the things are moving, and we are working on it. Our positional statement is going to come in next 48 hours. And then we, of course, we are going to give a consistent statement to Ministry of Health as well as ROC so that they can implement the long-term treatment, particularly telerehabilitation, and helping us out to develop low-cost apps for the people who are living in the remote area.
Okay, and we have a question about tele-rehab. So what have been the factors that have acted as a hindrance to providing tele-rehab services from your perspective?
Well, the biggest problem is those who have never seen the neurologist or the therapist. So we have tried to treat a couple of patients with the stroke whom the therapist has never seen. But biggest problem is challenge is the assessment. As somebody has pointed out the question, how to the Lucia, how did you assess the spasticity? There's no way you can do the assessment of spasticity on the tele-rehabilitation. So that's one of the biggest challenge. And we really need to look at some instrument where you could assess the spasticity on that, on some of the instrument or some way which we don't know. We really need to get onto somebody. Second thing is that many people are still not aware, particularly in rural area, how to operate the smartphone. Third is they may have low bandwidth or they are not able to connect and understand the language, what we need to do. So we may need to develop a language which they understand in their local community and provide them. Maybe what we are planning is that to develop a notebook, which may not be very expensive with certain parameters and the low cost apps which can speak in their local language and help them out at least to do some rehabilitation in a situation where they cannot go to the rehab center.
Do we want to squeeze in one more?
One more. We have a few other comments about to make as well. So one last question. Yes, it's fine.
And I think this could apply to pretty much everybody, but as far as, and it was asked before, COVID-19 patients who have neurological consequences, particularly those who have suffered from stroke, have you identified any peculiarities in this group in treatment and neuropsychiatric complications?
I could throw that open
Well,
to
the
panelists. Any of the panelists may want to comment on that.
So as a member of Indian Stroke Association, what I gather from my team of stroke specialists, that they have been seeing many unusual cases of stroke. And this include not only the ischemic stroke and hemorrhagic stroke, but also the venous stroke. We had a couple of patients where venous and the hemorrhagic, the ischemic, both were seen together, which we have never seen with the hypertension. So there are a couple of cases reported where they found that patient has the ischemic infarct as well as venous infarct, which is very, very unusual. And that is because of COVID has been seen. Also, what we have also seen is a couple of patients where new onset of seizure in a patient who has been very well controlled could be because of COVID infection. So these are some of the things which we have been identifying and picking up. And we are also looking up now that Bell's palsy, and if you do the test, we find that they may be positive. And we are also seeing Bell's palsy post-COVID when patient is recovering within 1 to 2 weeks of time. So these are some of the things which we have been seeing.
Okay, I think probably we should go ahead and end the webinar. I would like to thank everyone for participating. Thanks to the speakers and thanks to the audience. Here's the information about how to get CE credits. Please go ahead and email Tracy Mole at the World Federation of Neurorehab office in the UK, and she can help you with that. I want to remind you again about the virtual Congress next month. And I guess one question I would have is we were going to have a survey as to, oh, I'm sorry, one thing I need to mention. People have asked whether they can see this presentation again. I've been watching the questions as they've come up. And yes, it will be available on the World Federation of Neurorehab website within a week probably. And Victoria, any other place that they can find it?
They'll be able to find it on the Duke Neurology YouTube page. And they can also find the previous ones as well. So whether they go to the WFNR or the YouTube page, they should be able to see them all there.
Fantastic.
David, they should be able to see from here. Can you see the slides?
Yes.
So they go to World Federation of Neurorehabilitation, click the education and research, and then you go to webinar, and then you will be able to see it.
Okay.
Yeah. There are 5 people raise a hand, and can we just take a look at it to see if we can address their question?
We can. I will tell you 9 times out of 10 people raise their hands on accident. But we can go ahead and give it a shot if you'd like to pronounce one of those names for me.
I actually don't know how to check, to be honest.
Okay, so first we can go with Samira de Villa Vieira. She has her hand raised. I went ahead and gave her the chance to talk. Let's see if she has a question that she'd like to ask out loud. But we'll only give it a few seconds and then move on to the next one. Okay, moving on to Elba Rafael Goncalves. Let's go ahead and give them a chance. Let's see. Do you have a question for us that you might want to ask out loud? No. Yeah, most folks are,
Okay.
they do not intend to raise their hand when they do.
Okay.
All right. There are some questions in the queue, but we're at 10:08. So Dr. Good.
I think probably any of the other questions could be addressed by the speakers using the Q&A format. I think we should probably end here. I don't want to take this on too long. People have other responsibilities. Anybody else in the panel want to make any final comments?
I want to say something that IFNR need to develop, WFNR need to develop the courses. What we are doing only is during the conferences, but we really need to develop courses for different reason, one after one, maybe virtual now with this experience, so that, and certified courses, 1 week, 1 month, maybe every Saturday, because what we are doing on every Friday has been very, very useful. And I think this would be at a large number across the board, and WFNR should take the lead in that.
And Nemo, that's very good. That's a very good suggestion. I'll take this question. I sort of kind of take a lead on education. So we've been doing this 3 symposium as sort of kind of, take off a course, and certainly we'll take your advice. We are in the process to define some courses that in the long term in the digital format. Yeah.
So the poll is up here, Victoria. Maybe we can end on this.
Yeah, we can go ahead and end on this. Dr. Feng, do you want to go over the results or shall I?
You can. Thanks.
Okay. So what continent is everybody tuning in from? We have a major majority in South America from this webinar today. 76% of people tuning in are tuning in from South America. Second in line is Asia with 13%, Europe with 5%, North America with 4%, Africa with 3%, Oceania with 1%. Age group, the majority is 40 to 49 years old with 42% of our audience. 27% was 30 to 39, 20% 50 to 59, 6% for less than 30 and greater than 60. Professions, we actually have a majority of other, so that makes me think I might have missed some groups here. 46% of our audience classified themselves as other, 18% were physicians, 14% physical therapists, 7% neurologists, 4% occupational therapists, 3% speech language pathologists, 2% researchers, 5% neuropsychologists, which we didn't forget this time, and 2% trainees. And last but not least, have you had experience taking care of COVID patients? And 68% said no, 26% said yes, and 7% said not sure.
Okay. All right. Thank you very much.
All right.
again to all of the presenters and the audience, and we'll look forward to our next webinar in the future. And Victoria, thank you as well for your assistance.
Anytime. Thank you guys so much. And thanks to all the presenters for your excellent presentations. I hope everybody has a great one and a great long weekend if you're celebrating that.
Thanks, everybody.
Okay, take care.
Thank you, everyone. Thank you, Professor
Bye.
Good, Bokar, Franco, Lucia, Van,
Thank you so much.
and
Take care.
Bye-bye.
Thank
Victoria.
you.